Thank you for allowing us to share our research on Listening to Women, a qualitative analysis of women's experiences with mesh mid-urethral sling surgery. We have no affiliations to disclose. Stress urinary incontinence is an involuntary loss of urine with increased abdominal pressure. This impacts anywhere from 5 to 40% of women worldwide and is most commonly treated with MUS surgery. MUS surgery is typically performed with the use of a small strip of mesh, and approximately 250,000 mesh mid-urethral sling surgeries were performed in the year 2010 in the US alone. Currently, literature on MUS surgery focuses on quantitative outcomes research using mostly questionnaire data and database information. Our knowledge of what is important to women, however, and their perspective when it comes to MUS surgery is limited. Qualitative research methods help in guiding research on gathering more information that has not yet been published or not yet speculated on. This can be done using both inductive and deductive content analysis. Qualitative research methods do have trustworthiness guidelines as well as strict quality control criteria known as COREC to help maintain integrity of the research team study design, analysis, and reporting of results. The objectives of our study were to gain an understanding of women's perspectives, to qualitatively organize their experiences, and present those experiences as themes for future quality improvement and research. After IRB approval, an EMR was queried for sling surgery. A chart review was then performed to ensure that the appropriate surgery was performed, and inclusion criteria included participants who were English-speaking, 21 years of age or older, and had had a 6-month or more gap between the time of surgery and participation in the study. Initially, our study was intended to comprise of focus groups, but was amended to include telephone interviews as well, and all participants did consent to participate. Recruitment of participants occurred by phone call, and interviews and focus groups were conducted by study team members who were not involved in the participants' surgical care. Scripts were used to help guide the discussions. Discussions were then recorded, transcribed, and de-identified. And study team members used in vivo software to help code the data. The study team met on a regular basis to ensure that a saturation of ideas had been achieved prior to stopping recruitment for the study. The entire study team reviewed the codes, and 2 members coded all of the data thoroughly. The prompts served as themes for deductive content analysis, and information gathered that was not prompted was analyzed using inductive content analysis. Overall, 171 patients were identified through the query. 29 were excluded because of inappropriate or surgeries that were not mesh-related or mid-urethral sling surgeries. Overall, 11 patients participated. 46 were eligible but not called, as saturation of data had already been achieved. Demographics of our participants were limited in race and ethnicity, primarily white and non-Hispanic. Overall, women were asked about what led them to seek care for stress urinary incontinence. Several reasons were brought up by the women in our study and are listed here. Ultimately, we categorize these experiences as embarrassment and frustration with incontinence. Women were then asked to describe what their experience was like when they sought care for their stress urinary incontinence. Some women stated that they had gone in to see a physician for reasons not associated with incontinence, but were asked about their incontinence by a physician. We categorize these as a theme of physician inquiry or suggestion. On the other hand, some women went in to their physicians complaining of urinary incontinence, but were told to avoid inciting behaviors or to wait. We categorize these experiences as physicians serving as barriers to care. We also asked women to describe their expectations from surgery. While many described expectations associated with urinary incontinence, many others described bowel issues that they thought would be relieved by their mid-urethral sling surgery. We categorize these expectations as non-SUI related expectations from MUS surgery. While most women had a fantastic experience with their surgery and a fantastic outcome, noting that their life had changed or that the surgery was a miracle, Some women attributed non-urinary incontinence-related outcomes to their MUS surgery. For example, several women talked about bowel issues such as bowel leakage or associating the location of the mesh with discomfort associated with bowel movements. Women also talked about pain or recovery being longer or more intense than they had anticipated, as well as their partner feeling the sling or not knowing that the sling was going to be placed through their vagina. We then asked women what physicians need to know about stress urinary incontinence care. Again, they talked about how urinary incontinence is an embarrassing topic, but there was also this call to action where women thought that we needed to discuss urinary incontinence more openly and freely, and that there should be public service announcements to help women understand that. Despite the richness of the data obtained from our study, we do have some limitations. We overall had a small cohort that was limited in diversity, and this cohort was obtained from a single institution with surgeries all performed by FPMRS-trained surgeons. The strengths of our study are many as well, however. This is the first study of its kind to seek the patient perspective on uncomplicated MUS surgery. It challenges the status quo of success with MUS surgery and uncovers where action is needed for future larger-scaled studies. Additionally, it focuses on the patient and obtains first-hand information from women who have actually undergone MUS surgery. The themes that we overall uncovered are summarized here, and we're already using this information to help power additional studies to engage women in what matter in their care for urinary incontinence. We're happy to take any questions or comments at this time. Thank you.